Thanks for joining everybody today. My name is Yuli Kim. I am the medical director of the Philadelphia Adult Congenital Heart Center, and I'm a member of the JACC Consultant team. And I'm joined here today by friends and colleagues, Dr. Babar Hasan, who's Abdul Haq Endowed Chair Professor of Cardiology in the Division of Cardiothoracic Sciences in Sindh Institute of Urology and Transplantation in Karachi, Pakistan. And I'm also joined by Dr. R. Krishna Kumar, or KK Kumar, who's the clinical professor and head of pediatric cardiology at the Amrita Institute of Medical Sciences and Research Center in Cochin, Kerala, India. Welcome, both of you. Thank you for joining. I read with interest.
Pleasure.
You're welcome. I really read with interest your commentary about in response to the 2025 guidelines for the care of the adult with congenital heart disease in low and middle income countries. And I'm very glad to be able to speak with you today. I wanted to start off our conversation with a sentence that really jumped out at me when I read when I read your paper. This phrase was, these guidelines assume a healthcare environment where diagnostic imaging, advanced interventional cardiology, electrophysiology expertise, multidisciplinary teams, and structured transition teams are readily available. Although these principles shape excellent care in high-income countries, their direct application in low and middle-income countries presents considerable challenges. I would love for you to speak a little bit more about this sentence, and I think I wanted to start off with just asking you, what does adult congenital heart disease look like to you and where you live? Tell me more about the landscape of ACHD.
Yeah, so thank you very much, Yuli, and to the JACC editors for giving us this opportunity to write the commentary. It was great reading the guidelines, number one. It was really fascinating how the guidelines go into such detail. So, just to give you a perspective of when I came to Pakistan after my 11 years being in the US, what we saw in the US was a lot of adult repaired congenital heart disease, and their problems and their issues. And when I came to Pakistan, my very first patient who came to my clinic was a 40-year-old unrepaired tetralogy of Fallot who had significant polycythemia, had significant clubbing. And the next patient that I saw was a large VSD, Eisenmenger's 20-year-old, actually a doctor who was going through a medical school. So that was the kind of the shock that I came across. So the spectrum of adult congenital heart disease in at least our part of the world is a lot of unrepaired heart disease that comes because of late presentation, and that's one. And the second thing is that some of the countries like KK's like India, somewhat Pakistan also, have advanced in their care, and as they have advanced in their care, a lot of the repaired congenital heart disease patients are coming up with all the problems that you see in the high-income countries, but with very limited resources at our disposal to take care of it.
KK, what do you think?
Yeah, I sort of can reflect on all of this, and it's interesting that I just looked at two patients today. I'm going to give you examples. One was a 56-year-old with a corrected transposition and severe aortic regurgitation and heart failure. I saw another woman who had undergone a Glenn shunt, Kawashima version of Glenn shunt, 20 years ago, and wasn't a Fontan candidate, but was wanting to get pregnant. So, and she was a doctor as well. Therefore, it's a daily situation for us in trying to deal with this extraordinary complexity amidst trying to take care of so many other children, because we don't have enough people who can take care of them. So I have a center registry for adult congenital heart disease, which we built here, and it has enrolled 1,660 patients, of which only 649 have had either surgery or intervention. So that sort of puts things in perspective. You have a mixed bag here in our part of the world, as Babar said, unoperated, corrected, palliated, but not optimally palliated, or even suboptimally corrected for that matter, and with a host of issues.
That's really fascinating. About half have undergone repaired, KK, in your registry?
Less than half. Yeah, less than half, actually, about a third.
Wow. Yeah. So that's quite different than the United States or high-income countries where the majority of the patients are repaired. So what I'm hearing from the both of you is that the patients that you, not only the patients that you're taking care of are quite different, and they range, in terms of complexity with respect to repaired and unrepaired, but they range in age. And one of the things that I wanted to ask you is this concept of the field of adult congenital heart disease in high-income countries reflects often repaired heart disease in childhood. And what I'm hearing from both of you is that the spectrum is quite wide. It's quite different, and it may also lend to more of a blurring of this line of adult versus pediatric heart disease. Would you say that's the case?
Very much so. Very much so.
And that's really fascinating because, these guidelines are targeted towards adult congenital heart disease. There's an assumption that they're repaired, which is not the case for where you practice. And so you mentioned that, we just discussed the wide variation and the spectrum, I would say probably the big spectrum of congenital heart disease that you care for from infancy all the way to adulthood. But you also mentioned that there are different resources. So patient population's different, but the care is different. Can Babar, maybe you can start off with talking a little bit about how the care is different with respect to resources.
So I'll give you a couple of examples. For example, Yuli, one is a classic tetralogy of flow. So many programs, for example, KK's program does a lot of valve sparing. Whilst a lot of programs in Pakistan still do transannular patches. So, so it's a very common occurrence that you're going to see a 20, 25-year-old come into your clinic who was operated by an adult cardiac surgeon, because that's what it was available 20 years ago, and who had done a transannular patch. And now, they have significant RV dysfunction, they're symptomatic. And now, they're like in your clinic and you're like, what should I do? As a surgical candidate, they're pretty high risk until unless you're, a decently advanced program whose redo surgeries are good, and especially if the RV dysfunctional redo surgeries. And the transcatheter valve, just to give you an example, at least in Pakistan, we don't have an option. There is no transcatheter valve option. We just implanted 5 harmonies. The cost of one transcatheter valve is nearly 10 times that of a surgical valve. So that's one thing. The other thing I'll tell you, in Pakistan, for example, there is only one pediatric electrophysiologist in the whole of the country.
In Pakistan.
Yes, there's only one. There's only one. Yeah.
Oh boy.
So you have to really resort to our adult colleagues, and Frank, many times even making them understand the anatomy, making them have the patience of really dealing with the adult congenital heart disease patients, and then really kind of go through that. It takes a lot of encouragement from the pediatric side to do that. So these, this is the whole spectrum. Eisenmenger's pulmonary hypertension. Again, India is way ahead in the game when it comes to Pakistan, for example. We only have literally sildenafil and bosantan available, and that too, the cost is so exponentially high that from the get-go that even if you prescribe it, either they won't get it or they won't be compliant to it. So It's very, very different in that manner.
KK, what's it like?
Yeah, I'll I echo the same sentiments as Babar does. So there is a unique situation in India in that we do train to some extent in pediatric and congenital heart disease during the adult training programs. So this happens particularly in the good training programs that have high volume and that also have pediatric cardiology within their program. An example where I trained was All India Institute that had a pretty robust pediatric program. So during those months, you do get a good exposure to congenital heart disease. And in fact, during the examinations that you have, where you have to pass, you often do have a congenital case. Now, this allows for a basic understanding of congenital heart disease and allows for a fair amount of care to be handed over to the adult colleagues, especially in centers that don't have pediatric cardiology. This is very useful in areas such as EP. It's also useful in helping with interventions, for instance. So even when it comes to doing large vessel stenting and partnering with adult cardiology, understanding their hardware, that kind of crosstalk has been very, very fruitful. So there's a lot of improvisation that happens as a result. Definitely, we don't have specialized programs, and it's very hard to get anybody to commit to their lifetime in taking care of adults with congenital heart disease, because that's not thought to be a sort of a viable career to be so focused on this, because very few institutions will support that. So you're forced to do everything, literally.
And maybe that's more advanced in some sense, because you're able to care for this patient population without siloing it, but also being able to use the resources that you have. So I'm hearing, medications, procedures, devices. These are all quite limited and kind of taken for granted in high income countries, that you can just throw in a CRT device, maybe get an MRI, this, that, and the other, and we use it without thinking. And so I think these are the types of resources that that your commentary has highlighted when it comes to applying these guidelines in low and middle income countries and some of the challenges. And I'm hearing that there are ways to achieve that care. I wanted to ask the two of you to explicitly talk a little bit more about the way forward and how can we apply these guidelines with the differences in care paradigm in places like Pakistan, India versus other places like the United States.
So basically, Yuli, I think a couple of things that I think, and KK has been a huge mentor in that, in making me realize and understand that. One is the concept of what he calls always the bottom billion. So until and unless you do not, reach to the bottom billion of the world, truly the whole needle of inequity does not move. So 90% of congenital heart disease resides in low to mid income countries. And when it comes to any kind of technology or any kind of newer innovation that really has shown or demonstrated improved outcomes, if it is not scaled to the low to middle income countries in that lens, inequity needle ain't gonna move. So I think that has to be very clear. I think what is important is that how things are done in the low resource setting is different. I don't think one of the concepts that I had to myself get over with in my mind, in my frame of my mental model, was that, is this suboptimal care? It's not. It's different care. It's very different care. And there is a lot of things that you learn. There is a lot of multitasking. There is a lot of the whole concept of multiplication rather than addition. So you multiply your skills. And literally what you start realizing is that you don't have to sit in a silo. Structural heart disease on the adult side has really helped a lot of their understanding and their interest in congenital heart disease, because now the adult colleagues are way more interested in when we are talking about the valves and the heart failures and the devices and stuff like that. So that crosstalk has really helped us tremendously. So there's a lot to be learned, I think, from how things are done in the developing world or in the low resource settings, because as KK has always taught me, and I've learned a lot from him, is that when you start really using your resources efficiently and effectively, and you are actually achieving outcomes that are equivalent to many of the high income countries, it really makes a huge difference. So from an applicability standpoint, I think keeping that lens is very important. That, first of all, come out of this mental model that I'm providing, if I don't follow the guidelines, I'm providing suboptimal care. No. There is a way of doing it different. And you know what? When it comes to patient outcomes, patient, kind of safety, all of them can be achieved in doing things very differently at the same time.
KK.
I think Babar has put it really well. It's all, of course, that's very true that there is a lot that both the environments have to offer to each other. We do have a model that is relatively efficient and very lean in terms of resource consumption, especially human resources. We do improvise a great deal. We also have our own technology that's really started to make a difference. For example, the implantable valve that has come out of India, my valve, has become a very the lowest cost option available for both TAVR as well as pulmonary valve. Although even this is fairly expensive. The drugs that are manufactured now in India are also reasonably low cost, although it could still be lower. And those are, but truth is that we still are only scratching the tip of the iceberg in terms of numbers. That has to be acknowledged. Unless we acknowledge that, we don't realize how immense the problem is. The problem is on a scale of, because I think so many are not even seeking attention. Only now we've started to realize the magnitude. And the problem is not just medical. We have to understand the social angle, the economic angle, the fact that these patients would want a livelihood, these women would want to have children, they want to have a life. Now that becomes way more challenging in our part of the world with all the cultural issues, the socioeconomic issues. Those things are actually, to me, the most hardest challenges. The last woman who wanted to get pregnant, who I said would be unacceptably that because she's uncorrected, was openly weeping in my clinic. So those are problems that really don't have easy solutions. And in addition to that, of course, we need to recognize the issue of equity, no question about it. And we need to reach out in a way that we can provide some level of care, at least to the average citizen.
Babar?
Yeah, and going back to what you were saying about the way forward, I think, Yuli, again, acknowledging that knowledge, there are many forms of knowledge around the world, globally. And I think not tapping into that is, in a way, is a failure on our part. I think that bilateral collaboration really can help. So when it comes to writing guidelines, whatever, really having that bilateral collaboration, not from the lens of tokenism, not like having somebody like a brown guy sitting and having tokenism there. No, that's not. I think it has to be Larry from the lens of humility, that there is bilateral knowledge that can be shared. That's one. The second thing, I think, and I'll tell you that, the strength of the South-South collaboration, as in what I say, and there's so many things. I just now came from the cath lab and I stented a PDA of a 9-year-old tetralogy fellow, pulmonary late presenting with a hemoglobin of 25 and an INR of 2. And why did I stent? Is because of the work that KK has done, and in which we have shown that if you improve their saturations and then take them to surgery a couple of weeks later, they do better. And so that South-South collaboration has such a strength to it that we need to really kind of harness that, and that is one of the words. And I think the crosstalk between our adult colleagues, I think that is now, I think it's at a tipping point, structural heart disease and all of this, and really kind of doing those collaborations. Those are a couple of the way forwards that comes to my mind.
That's great. That's great. And I will say, just even talking to the two of you over the past, this morning has been extremely informative for me. And I think, what you just said, Babar, was so important in terms of just this term collaboration, which is, and bidirectionality, which kind of goes amongst many things. So you can say that between adult and peds, you can say that between structural adult cardiology versus congenital, you can say that with high income countries, with low and middle income countries. That is the key, I think, to everything that you're saying, because once you practice humility and listen with compassion and real openness, then you start to learn. And just listening to the two of you speak about some of these vignettes of the patients that you've taken care of today, just even today, has been so eye-opening for me. And it makes you really think a little bit about the way you practice in your own world, and how it could be informed by the experiences of others. And it's truly important, this message that you're conveying. And I do think that including people not in a tokenism sort of way, but including people and having more inclusion when it comes to writing these guidelines can inform them in a way that really benefits everybody. So I just want to say thank you for all your time and writing this commentary. Like I said, it was such a pleasure speaking to both of you, and I learned a lot, and I hope to see you two soon.
Thank you very much.
Thank you for this opportunity. I enjoyed the conversation.